Hello and welcome to another episode of the Melbourne Athletic Development Podcast. Today we're very lucky to be joined by Richard Fernandez. I'll pass over to you, Jack, to maybe introduce Richard, as he's a colleague of yours from Latrobe.
Yeah, certainly. So I met Richard at Latrobe. He works in the anatomy department, and me being very curious to continue to learn and develop my skills of anatomy, I got in contact with Richard and found an ally and someone who started to look and understand anatomy, and specifically the fascial system's involvement in the musculoskeletal system. So I thought it'd be really valuable to have you on today, Richard, to hear your thoughts and get your expertise and get some insight into what you've done in your academic and research career. So just to give some context to the conversation, do you want to give a brief introduction of yourself, including what you've done in your professional career?
Sure. Thank you very much, Jack and John, for inviting me. It's a pleasure to be on your podcast.
You might not say that at the end, mate.
We'll wait and see. So I've been a lecturer out at Latrobe for about 23 years now. I started there as a sessional staff member, but I did my Bachelor of Science at Melbourne University, and I did a year of honours, and I was quite fortunate to do a project in topographic anatomy. It was interesting that I got my first preference in pathology, but some students got better marks than I did to get into the anatomy honours project, and I really wanted it. And a couple of days before my birthday, I got a letter saying you've been accepted into honours in anatomy, and that was a very defining moment in my life. I could have taken pathology, but I really liked anatomy, and I ended up getting that project, and that kind of kick-started my career in anatomy. And in that project I looked at the hip. I looked at hip replacement surgery. So after my honours year, I was very fortunate to be at the right place at the right time. I got a few teaching positions at Latrobe and Monash universities. I started to lecture at Latrobe in a couple of subjects, and out at Monash as well, and also demonstrate anatomy.
And with that in mind, is teaching always been part of the interest for you, or were you much more on the side of like just actually wanting to research anatomy and look at that?
That's an interesting question. I really wanted to do medicine when I was in high school and university, and when I was studying anatomy and studying science, I thought, how am I ever going to use this?
Yeah.
And it was only when I actually finished my science degree, and it was quite ironic that I didn't get into medicine, but I was teaching first, second and third year medical students immediately after my degree. And that kind of showed me that there were brilliant skills in science, the observational skills.
I think one of the things that's interesting with anatomy, and I think all of us probably share a keen interest and love for anatomy, that on the surface, particularly as an undergraduate, you don't necessarily maybe understand the relevance of getting into the nuances of, for us obviously it's musculoskeletal tissue that we're typically interested in, but you think, why do I need to understand this at this level? But now that we're 10, 12, you and I are getting towards 15 years post finishing undergraduate, it's really, really clear why having a strong understanding of anatomy is important clinically. And even this week, we've got a student with us at the moment from Latrobe, and Jack and I actually take a perverse amount of pleasure in needling them about their anatomy understanding.
Well, I think you do anyway.
I'm sure you enjoy it too. And they don't seem to quite get what the value is, but I think for us, it very much starts to put the picture together clinically in what we do with our patients. I guess that's a lot of talking, but have you seen your view of that change over time? You mentioned that at the start you were not really sure where it was going.
Well, yes, absolutely. I think to answer your question with a small response and then elaborate later, during one's education, it really depends upon the educator.
Yeah.
A good educator will show the relevance to the student of why they need to know it. And if a student can see why they need to know it, its direct application in their career, they're more inclined to enjoy it, understand it, and pay attention to it.
Yeah.
If they can't see that relevance, it might just come down to a level of memorization. I need to memorize this to get through to the exam. And I think for me, in that period of time before when I finished my degree and I was trying to figure out what to do, what you just mentioned, John, the interest to learn more, the interest to specialise in just one subject, instead of medicine, many different subjects, just specialise in anatomy. That's what led me to do a PhD. And I think...
What did you do your PhD on?
I looked at hip fracture prevention.
Mm-hmm.
So it was a very multidisciplinary project that looked at topographic anatomy, a lot of biomechanics, impact biomechanics, epidemiology, and even computer modelling, finite element modelling, so some engineering principles.
And what did you find through that? What did you
I think the main thing is, so I looked at developing the specifications for a hip protector device.
Yeah.
So older people, when they tend to fall over, if their greater trochanter contacts a hard surface, enough energy is generated to fracture the hip, or fracture the greater trochanter or cervical region of the femur. So hip protectors exist, but the big problem is the low user compliance.
Yeah. Well, I guess the biggest issue that you tend to have with that, having sort of worked in aged care, is typically either the staff are not necessarily putting them on to these patients, but a lot of them actually have, mental inability to actually maintain like memorization of that. So they've got Alzheimer's or dementia, and so that creates a lot of issues in itself. They don't actually remember to put them on.
Yeah.
So as you said, the compliance to it's a real issue, and you'll find them on the floor with a broken leg, and you go in and you're like, your hip protectors are sitting there doing nothing.
Yeah.
Potentially they may have actually helped in this situation.
So one big finding from that was, yes, there are hip protectors out in the market. To use Animal Farm, all hip protectors are created equal, but some are more equal than others.
Getting very, very Orwellian very quickly.
Yeah.
So I think the ones that work quite well may not be as comfortable. So I looked at...
It's made out of steel. It's just like a big...
polymethyl methacrylate, to be exact. But if we go and buy a suit, we want to make sure the suit fits or the clothing fits, and especially with shoes. So why not make the protector fit that particular individual, or make more sizes of protectors? I think there was just a small and medium protector in existence, and they're so variable. So I looked at fine-tuning the anatomical design of a protector to suit particular proportions of the population. So it's a nice, comfortable anatomical fit. So that was one of the main findings. But another really cool finding was trying to figure out the material properties of muscle under dynamic loading.
Yeah, that's interesting. We actually have had a few people on, and it's an area that Jack's a lot stronger than I am, but as soon as he starts talking about the dynamic architecture and dynamic behaviour of muscle, you see their eyes sort of start glazing over.
Well, I think specifically too, like in biological systems where the biomechanical properties of tissue change, whether it's more passive or active. But I remember you telling me a bit about some of your research findings with some of the finite element modelling of looking at when you create a compressive force onto soft tissue of the distribution or dissipation of forces through the myofascial network. It'd be interesting to hear a little bit about some of that stuff, because I think that's something that
people don't necessarily understand intuitively that, as you said, the
interconnection I think is the big thing, because this is something we're obviously interested to talk to you about today when we think about anatomy, of how we actually visualize, or the conceptual models we create about anatomy, because the reality is, I think I've mentioned this to you before, anatomy is based on the anatomist in the sense of how you actually go about dissecting the body, and specifically what you do with all the fascial system and network, because the reality is when we look at that textbook and we see this nice
perfectly
clear,
defined separation of tissue,
this clear origin and insertion of a muscle, and you're like, yes, it's just so nice and neat, and you can see rec fem completely separate to the other quadriceps muscle, and don't even take into consideration the aponeurotic fascia, such as the fascia lata and the myofascial expansions going between the aponeurotic fascia and the muscles, or even between the muscles.
Absolutely. I think and this is where going back to how one studied anatomy is important. When I studied, I had the honour and pleasure of actually being able to dissect a cadaver in my second and third year, and many specimens during my honours and PhD years. And that gave a unique, it produced a unique skill, but it also gave me a unique way to spend time to examine these things. A shout out to my anatomy lecturer, Professor Chris Briggs.
Was he your lecturer as well?
Yeah.
He was our lecturer.
Yeah.
So he's my lecturer.
I have a good story about Chris. I won't go into it, but he ripped into me in a lecture once, actually.
I can see why. Yeah.
That's probably fair.
So you're always willing to express your opinion when you disagree with someone.
Yeah, my tendency to open my mouth too quickly.
But the best advice he gave me, and I tend to give my students as well the same thing, is spend time in the laboratories. Examine the specimens. And yes, I think it is very expensive to offer a dissection-based subject and course at universities nowadays. There's a big shift away from that.
That's disappointing, because I feel like that was one of the best experiences. We were super
Absolutely,
lucky.
yeah.
Like we even as physio students, we got to do dissection, which I know that a lot of other physio schools do not get that privilege. And to us, like, I think, I definitely didn't. I'm not sure about you, Jack, but I didn't recognise how significant that was in terms of our, understanding and development, because you expect, everyone gets to do this, but it's clearly not the case.
Well, I think part of that, though, too, sort of comes back to talking about education, of giving context to why you learn things as well. And I think that's one of the big criticisms I have of, say, like the curriculum at Latrobe Uni, where you have this common first year of teaching all these basic sciences, which is actually very valuable work, regardless of, how that's presented, whether you think it could be better or not. But for a physiotherapist, anatomy is such an integral component to what you do within the real world. And
any clinician or practitioner that works in
absolutely
anything to do with the body from a musculoskeletal point of view.
But the problem that you have is, if you're going, okay, well, here's your origin, here's the insertion, this is what this innovation is, that's all well and good, but what does that actually mean in terms of what you do in the real world? And I think the biggest one actually for us, which I think could be done a lot better, is surface anatomy too, because we need to be able to orientate ourselves in the body by, having a body in its whole form and being able to palpate through skin and other tissue structures to be able to identify what we're actually feeling, which is obviously very significant from understanding pain generation and structures that are potentially involved. But I know for you, actually, I know we had this conversation before about education, where you'll often set small assessments early in the semester, which a lot of students may have difficulty with. And it's like this process of actually getting them to struggle, because I know that you're very big on focusing on building concepts, not just your ability to regurgitate knowledge, but your ability to actually utilize that in a particular scenario.
You spoke about that before in terms of teaching. How do you get that balance right for you of getting the concept across, as well as trying to make sure it's relevant to them, but still, developing their understanding and their ability to recall it when it's needed?
It's a very challenging question to answer.
Well, you've obviously developed it in your professional teaching.
Look, I think showing students a direct application.
Can you give us an example of
sure.
what you do?
So it's a direct application, and showing them how they can use it. Also, I think a level of inspiring the student to want to learn. You can lead a horse to water, but you can't make it drink. You can tell them this is what they need to know for the exam, and they'll try and memorize it. If they are really interested in learning, they'll try and understand it so they can explain it and then problem solve it. I think coming back to the education thing, there's Bloom's triangle or pyramid, which starts off with just remembering and then trying to understand, and then going to the next level of applying and then problem solving and so forth. So I think it's a combination of all that. So let's say they want to learn the quadriceps. We might start conceptually and say, it's a group of 4 muscles, it's in the anterior compartment of the thigh, it's in the front of the thigh, there's the fascia lata encompassing these muscles along with many others. And quadricep, look, what about its name? What about its nomenclature? There's beauty in its name. A lot of people just call it the quads. But quadraceps femoris is telling you four seps, four heads. So it's got four origins. Femoris, it has to be on the femur, has to be on the thigh. So a four-headed muscle in the anterior thigh. So you can start to picture that now. And I think I use drawing a lot in my teaching. I think I've used it as a student, I've used it as throughout my educational career. And I'm a firm believer in it because you can use it to actually describe a concept and then gradually add detail. It's a great way to engage students. So therein lies the other part of education, engaging them to learn by doing something. So they can draw something, they can go and examine a specimen model themselves, and then, if they've got the opportunity to dissect that. So it's a combination. But coming back to quadriceps, there's the muscle, they'll go and look at it. A lot of the time, educators sometimes forget why it's called topographic anatomy. It's always referred to as just anatomy. I am a big proponent of the word topography because that's what we're learning. It's what the muscle looks like. What's its shape? What's its size? What's its fiber direction? Do these fibers vary? Describe the topography. So if you look at the topography, then you can start to see the nuances and the beauty of the muscle. So for example, vastus lateralis, if you look around the knee, near the quadricep tendon, its fibers are very oblique. Whereas vastus medialis will extend more distally, its fibers are horizontal at that point. So you think, why? Why have we evolved to have a muscle, a four-headed muscle, to look like this at the knee? But then you think about the patella. The patella slides up and down between the femoral condyles, brilliant anatomical pulley. But as we walk, if vastus lateralis is pulling the patella laterally, there's a chance it can dislocate. So there's a mechanism to prevent that. There's the raised lateral condyle of the femur. So that's a passive mechanism to hold the patella in place. And then the active mechanism are those horizontal fibers of vastus medialis. So it's a bit of a tug of war between these two quadricep muscles and the patella to stabilize it. Now, if you then apply that in a clinical scenario, someone's fallen over or, maybe been doing some sort of martial arts, it happens a lot. Football injuries, a patella dislocation. What force or what external load, to speak from a biomechanical point of view, has caused that patella to come out of its groove? Is the force of pulling, the tensile force of vastus lateralis, stronger than medialis? Is there an imbalance in the topography or the shape of quadricep in this individual, or has an external load added to the force of vastus lateralis to pull it out? And have to get the student to think about that. So we all know it extends the knee, but then how does it extend the knee? What happens at the end of extension? And then you can start to go on, you start to build. So
I love that you're sort of going into this depth, because I think it's one of the things that when you start to understand, and even as you said, just explore the topography, you start to put together a picture of how it functions. And I think this is the step that, as a younger clinician, you don't necessarily start to think, okay, what I'm seeing here, how does this actually relate to what it does, and why, as you said, has it evolved to be able to do these things, and why has it now got these functions? I always find it quite interesting, and Jack and I always have probably complained about this, but when someone will say something is vestigial, and you think, well, it wouldn't be there if it was vestigial, right? And I know that there's arguments either way, but just because you can survive without it doesn't mean it doesn't do anything. And I know that you and I have discussed this before when it comes to, say, plantaris.
Yeah.
So there's this, in my mind, ridiculous surgery that they do for Achilles tendon pain, where they blame the plantaris for causing medial irritation to particularly the actual tendon and the sheath structure, and they remove the plantaris. But clearly the plantaris has quite a significant effect on what actually happens in the foot and around the ankle, and it has a very high number, you probably know much more than me, but of proprioceptive fibers. So removing that is taking away a function that tissue has, even though from a maybe mechanical tension standpoint, it doesn't necessarily create as much tension as the other parts of that calf complex, but it's clearly there for a reason. And removing it, I think, is simplistic and naive. But it tends to be a surgery that's still done quite often.
I think you raised a really interesting topic there. As a scientist, what we do, how we implement things should be clearly based on evidence.
Yeah.
Unfortunately, in medicine, it takes time to figure these things out. So, for example, in the early days, meniscal tears, the medial lateral meniscus.
Yeah, they would just do complete meniscectomy.
Yeah, take out the whole meniscus. But it's a brilliant shock absorber. It's only a few millimeters, but that's enough to actually prevent significant load transmission from the tibial plateau into the femoral condyles. And all the individuals that had these menisci taken out started to get osteoarthritis really early.
Yeah, but extremely quickly, yeah. I remember there was an interesting article about like a whole basketball team. I think it was in like maybe the 70s when they started doing these surgeries, and they just said prophylactically they basically took out everyone's meniscus.
Yeah, and I remember the other very famous study, I think it was from Scandinavia in the mid-2000s, of looking at doing meniscectomy versus a placebo surgery.
Yeah.
Where they would, because as is often the case when you think about any intervention, a surgical intervention can have a very powerful placebo effect because it's the most type of invasive intervention you can use. But when they were comparing the short-term effects of the potential benefit of getting surgery, which you may see, you saw a similar effect comparing it to a placebo, where all they did was make a superficial incision to make it look like they'd actually had surgery. But then, of course, you're still suffering that mid to long-term issue of, if you do get the actual meniscus removed, of early OA.
I think, Jack, this comes back to your question with biomechanics and so forth. We're still learning so much about anatomy. I mean, people will say, we've known about the body for over 2,000 years, from Galen all the way to Vesalius and then Gray and all that. What else do we need to discover? Well, we're still mapping certain things. So we know where the muscles are, we know the neurovascular supply, but there's lots of variation. And Jack, this is your kind of pet interest, the fascial planes. There's so much more that needs to be discovered there.
Here's a question. Yeah, sorry, Jack.
You go.
I know it's a frustration of Jack's, and we talk about this often, but why do you think fascia is considered the poor cousin of every other sort of...
The thing that gets in the way, so to speak.
It's like it's the poor anatomical cousin of everything else. Like, no one seems to pay any attention to fascia, even though it's clear that it has significant function in the whole musculoskeletal unit and how it functions, in that complex nature. And without it, anatomy would not work in any functional manner, yet most people almost disregard it. And as you said, Jack spoke about, these beautiful dissections where they just remove large pieces of the fascia and just go, that wasn't there, don't worry about that. Just look at this beautiful muscle with the tendon, beautifully connected to its origin and insertion.
That's a good question. I wouldn't consider fascia the poor cousin.
No, I think anatomists wouldn't, but it seems like a lot of people almost disregard it.
Certainly. I think it comes down to seeing it work. And for me, seeing it work would be prosecting a specimen and just pulling on it. Showing students, demonstrating. This is where the beauty of being a demonstrator is so exciting. You get to show someone how it actually works. Perhaps I can answer that question with an example, an evolutionary example. So you may be familiar with ligamentum nuchae, that thick ligament at the back of the head from the occipital bone. It comes down, it blends into the supraspinous ligament. But then it's got a really interesting fibre orientation where those fibres blend into the fascia around the scapulae. So because the line of gravity runs by our atlanto-occipital joint each time we walk, so during a gait pattern, we heel strike and equal and opposite forces, there's a force or a load that will go through the body, but that causes the head to kind of nod forward. And ligamentum nuchae supports that. It actually stabilizes the head, preventing that nodding forward. And if you think about humans, well, we've evolved to run. So as we run, we wouldn't be able to go very far if our head kept nodding forward like this, like birds.
Yeah.
And if you watch birds move, their heads, they don't have that. So when you think about that ligament, how it blends into the fascia, and the fascia around the scapulae, it's quite superficially, it's quite unique. It's soft, it goes hard, there are fibres that run in many different directions, it's actually quite complex. But that ligament blends into that. And when you think about running, we start to flex our forearms at our elbows, and then we start to flex and extend our shoulders like this. And probably recording me doing this as well. So this action, of running, moving our arms, is pulling the fibres off that ligamentum nuchae, stabilising our head. So try running without moving your arms. You'll actually contract your muscles a lot more, muscles around your neck a lot more.
To try and stabilise your head.
To try and stabilise your head. And especially running on a fairly hard surface, try to keep your head steady. And this is the interesting thing. Yes, certainly we should be teaching a lot of this, but it depends. It all comes down to, does it fit the curriculum? What do students need to know, and how can they apply that? Keep it simple. And I think this is where the beauty of an elective subject, at a university where we can explore a lot of these things is exciting. And I used to, I developed and ran a subject like that for a while. I think COVID put a bit of an end to it. But I ran it from 2016 to 2019, and we spent time looking at all these nuances of anatomy and, getting students to dissect as well. So I think the fascial system doesn't get the attention it deserves. It certainly needs a lot more. And we're only, looking at the tip of the iceberg with how the fascial system fascial systems of the body relate to one another, relate to the deeper muscles. And just to go back to ligamentum nuchae, if you have the pleasure to dissect and you look at its fibres, those fibres of ligamentum nuchae continue with the supraspinous ligament. It runs posterior to all the spinous processes, gets into the pelvis, and then on the posterior pelvis, those fibres continue into the sacrotuberous and sacrospinous ligaments. And then if you start to look at the gluteal region, those fibres there are thickenings inside the gluteal muscles that allow those fibres to then continue into the proximal thigh. So, and then, think about other ways we use anatomy, maybe with the alternative therapies. There's a really interesting shiatsu point, I hope I'm pronouncing that correctly, where they press at the base of the skull. And pressing that point stretches ligamentum nuchae. It's meant to relax part of the back and so forth. But this is, an ancient art that I think Chinese or Japanese practitioners have been doing for a while. So I think...
The interesting thing about that is, as soon as you say something like that, you'll get pushback from people saying, oh, well, there's no evidence for that. But the funny thing is, if you start talking to them about the anatomical understanding, there is a clear theoretical basis for why it potentially works. Obviously, it needs to be studied in a controlled trial. However, it's not completely unfounded for you to explore that idea, because there is the anatomical foundation for it.
Yeah.
And that's the frustrating thing that I know you get really frustrated with, and I sometimes get frustrated on your behalf, when people make statements about, oh, that doesn't work, or that's not possible, and you say to them, well, do you actually understand the anatomy? Do you actually understand what these fascial systems do? Like, even during the week, actually, it was quite interesting. We've been posting a little bit more on social media, and we had a seminar here during the week of some young guys who were in a running club, and one of our physios, Dom, was taking them through stuff, and they were asking questions, and one of them asked the question that a lot of runners ask, what do you do for your ITB if it gets, they get ITB soreness around their knee? Do you roll it? Do you stretch? and they go, oh, I've heard you can't stretch it, it's not possible, and all these kind of things.
Can't stretch it.
And there's all these weird things of like, people dissecting out, the ITB and its connections, and then showing, okay, like we don't physically have the strength to stretch it and all those kind of things. But what they're not necessarily understanding is the way in which those structures and the different layers actually interact with each other. So, Jack's educated me much more than I've probably looked for it myself, but there is potential for sliding between these tissues, and particularly because within these tissues, if you do start to either stretch, even if it's the surrounding tissue itself, or you start actually moving, you get release of hyaluronan, which will actually allow for some actual glide to happen.
And this is the issue too, where we look too much anatomy as
a fixed,
as mechanical tissue as opposed to biological tissue, because when you stretch it, there are obviously mechanical properties, but we also have to remember that those mechanical properties are not fixed. Depending on the magnitude or the rate of force development, we see non-linear behavior. But and also as you stretch it, you actually get secretion of certain factors which alters the properties of the tissue or the sliding of the tissue.
Yeah, and I guess that probably brings up a question of how do you think doing study on, say, cadavers actually is similar to studies on, people who are alive? Because I think anatomy will function differently in those, not always, but it can function differently in those scenarios.
That's a very good question. I think it really comes down to what you want to do. And firstly, going back to what you were saying before, in order to figure out something, the basis of science is to see what the problem is first. So for example, these runners say there's a problem with the iliotibial band. So look at the epidemiology first. How big is this problem? Can we solve it? Then design a series of experiments that test that hypothesis. Do the investigations. Do it in a rigorous manner. That's the important thing. Science needs to be rigorous. Do it in a rigorous manner. Get some results. Analyze those results. Try and interpret the results as well. See how it links up with existing literature. Publish it. See what happens. Then someone else might try and repeat that. Someone else might take it to the next level. The original researcher might say, I've learned something from this. Now I can look at this specific area of the iliotibial band. So I like the iliotibial band a lot. I looked at it a lot in my PhD, and I've kind of mapped a lot of the things around the gluteal region. But it's truly an amazing structure. Look at the textbooks, and even looking superficially, you'll only see longitudinal fibers, but you look on the deeper surface, there are horizontal, there are oblique fibers, there's thickenings of gluteus maximus blending into it. So I think, coming back to that question, looking at the cadaver, looking at the human, well, it is the same. The benefit of dissecting the many cadavers is you get to see the variation, you get to see the nuances and the detail of the structure. You can do an anthropometric study where you'll measure the variation in a population, get a good idea of what it's like, or a reasonable idea of what it's like, and then you'll try and apply that clinically. So there needs to be two parts to it. There needs to be the gross anatomical part, and then the clinical application of that part.
I think also too, what you're highlighting that I wanted to mention before when you were asking the question, John, about why is fascia neglected, there's a couple of things there to consider too, where most fascial sheets, whether it's the ITB, fascia lata, crural fascia, have multiple layers. And one of the things that a lot of people will say is like, well, fascia, these aponeurotic fascia are just all these disorganized collagen laydown. Well, but the problem that you have is like, well, hang on a second, within those fascial layers you have sub-layers, and those layers can glide independent of each other. The reason why you have multiple layers is because forces are being distributed in multiple directions depending on what contraction is happening above or below. I think one of the issues that we have too, and I know I've talked to you about this, is because cadavers are embalmed, those sub-layers actually become glued to each other, so you don't get an appreciation for that. I know I've talked to you before about some of the work of Carla Stecco over at Padua University in Italy. She does all these brilliant dissections of unembalmed cadavers, which is
Is that very different to do?
You can't do it here in Australia.
You can.
You can? Okay.
I mean, it does require ethics and so forth, but Melbourne University runs an absolutely brilliant body donated program, and I think what we've got to firstly do is really thank the individuals that donate their body. It's such an altruistic
I find
thing.
it so strange. Why the hell would you donate your body for someone to cut up?
I think
Especially if it was me cutting it up. I'd be like, this idiot's cutting me up.
well, and this is why we train students. I give a lecture on the ethics behind the body donor programs, how it's evolved from the early 1500s, where Vasilius used to take the remains of condemned criminals that have been executed and then
It sounds like
dissect
China,
them.
doesn't it?
Well, there's always the dark side to anatomy and the ethics. I mean, what happened in
And
World War
human
II?
behaviour in general.
Yeah, certainly. But I think it's very important to acknowledge that if an individual is giving their remains to learn, it's an amazing gift, and we honour that in many ways as anatomists. There's a community around Australia that honours that in many ways. But Melbourne University, for example, they run a program where they receive an individual's remains after they die. It's checked, of course, for certain conditions, and if it passes that, it's embalmed, or it can be used for research. And this is the thing, a lot of people will donate their body to be used so that it can save lives in some way. And then it does. So surgeons might practice a particular procedure, and they might want to practice on an unembalmed cadaver or a fresh frozen, so they'll freeze the remains and then thaw it out and dissect. But in a lot of the educational institutions, we embalm the cadavers because it lasts a lot longer. We can store it in many different ways. But after we've used it, we return those remains to Melbourne University. And I speak about the body donor program in Victoria. Every state has their own donor program. But those remains go back to Melbourne University. It's all cremated, so that individual is then cremated, and the ashes go back to the family. And Melbourne University actually runs a Thanksgiving service where they'll invite the family of the donors to come and attend, and they'll invite the students and staff that have examined and explored these human remains. And it's a very powerful event. So I think how we conduct our anatomical research is important. The ethics behind it is really important. And if it wasn't for these donors, we wouldn't be able to do the work we do. We wouldn't be able to make these discoveries that change so many things. So for example, little things that I've found out with hip replacement surgery, part of my results suggested if you just tilt the prosthetic cup about 10 degrees in anteversion, reduce the rates of dislocation. And if we hadn't measured the normal anatomy, hasn't measured the variations, haven't looked at all that, we wouldn't have come up to that. But if we can reduce dislocations, think about the implication of that for someone that's had hip replacement. So a surgeon can then say, for 6 weeks, don't do this movement. Don't sit down and cross your legs. And or they can tilt the cup to prevent that from happening. And just making that small change then alleviates a lot of pain and suffering for that population. So I think that's one of the brilliant things about doing anatomical research.
Well, I also think too there seems to be a revolution going on in anatomy of thinking, okay, we have this fascial system that is essentially ubiquitous, and I think that's probably one of the big things of why it's commonly removed, because if you keep it there, you start to realize, oh wait, so like this actually continues down into here, and you see this myofascial expansion of the vastus medialis into the fascia lata, or like I was reading an article recently of, we actually see this sort of aponeurotic extension of the proximal rectus femoris into the ASIS, and you start to appreciate all these continuities within the body. The problem with that is then we need to start thinking of using a very different conceptual model of how of what anatomy is and what that means for movement and locomotion. Because instead of seeing muscles as independent actuators, you start to realize that there is continuity between compartments, even like with lateral force transmission, but obviously longitudinal force transmission. I think the thing that's also interesting too is these are not sort of vague theories. Like there's a lot of researchers showing these myofascial planes. Like Andre Fleming's stuff is really valuable with and probably the most well established of looking at, say, latissimus dorsi down into the thoracolumbar fascia to the contralateral gluteus maximus, and then you can actually see continuity of that into, say, vastus lateralis. And there's more and more coming up when you think about some of the myofascial chains through the interior body, when you think about pec major, through the rectus aponeurosis to the contralateral
clavipectoral fascia as well.
Absolutely. So there's this expanding knowledge of going, okay, we probably need to stop cutting through the fascia and follow it. And I know some of the pictures I've seen of some of Carla Stecco's work where if you remove the skin, if you remove the superficial fascia, but you keep that aponeurotic fascia, the stockings of the arms and the legs, and things like the rectus aponeurosis and thoracolumbar fascia, you start to get an appreciation of this continuity within the myofascial network. And that's obviously really important, I think, for us as clinicians, because then you start to appreciate, okay, someone's got a hamstring strain. We may see deficits in their hamstring capacity, but do we see deficits elsewhere within that kinetic chain? Whether that be related to their calf, their tibials, their back. And it's interesting to note too, I was reading an article recently from Paul Hodges' lab, who, I don't know if you know Paul Hodges, he's a professor of in physiotherapy at the University of Queensland. He was one of the early pioneers with Gwen Giles looking at this concept of motor control. And it's interesting to see how his work has really expanded our understanding of the sensory motor system. And in fact, this idea of, say, alterations in motor control isn't just limited to the behaviour or dysfunction within the particular area we're talking about, i.e. glutes or the abdominal muscles, but also seeing alterations in sensory motor control when you see dysfunction elsewhere within the kinetic chain. So if you see, say, dysfunction within the neck, you may see changes in the behaviour of the muscle activity within the lower back. So all of a sudden you're starting to go, well, okay, I need to probably take a step back here. Am I becoming a little bit too reductionistic of only looking at that region when someone presents with a problem, i.e. I've got low back pain?
And I think that starts to highlight too that it goes in the other direction as well. So when, say, for instance, there's, say, muscle tissue damage, sometimes you'll see, or not sometimes, often you'll see really varied function. So you might say, oh, if you look at the tissue, you have an MRI, it's like, oh, that's a grade 1 or that's a grade 2, or it involves the tendon or it doesn't involve, this tissue structure. Yet what they can do may vary. One person can hardly walk, say, from that hamstring strain. The other one is running with very minimal discomfort.
Absolutely.
And in your mind, you're thinking, well, how, if they've got the same level of damage on imaging, do they have very different function? And this starts to explain it. It's like they understand, for them, for instance, there might be force transmission happening in, across planes.
In different layers,
and they can actually kind of get around the problem and still create, adequate function.
I think this comes back to two things, structure versus function. We've evolved to have a particular structure for a particular function, and every structure of the body, its intrinsic shape, its extrinsic presentation, and so forth, is all geared up towards a specific function. And like a nice example are the trabecular systems in the proximal femur. So there are curved trabecular systems that support the femoral neck and head, and they're designed to withstand compression and tension as they transfer load from the trunk into the femur, into the femoral shaft. So it actually transfers the load from the head and neck into this thick plate of bone called the calcar femoral that then shunts it into the shaft. So it's quite unique that bipeds have this internal structure of the femur. So that's one, structure versus function. But going back to the fascia and learning and trying to tie it all in. So in first year, let's speak about the common first year at Latrobe, for example. So students studying a first year anatomy and physiology subject will look at fascia, and they'll look at tendons, and they'll say, oh, well, deep fascia is classified as dense irregular connective tissue.
Well, just before you go on, that's a good question I was going to ask you, because it seems to be one thing that we probably need to clarify now is what do we actually mean when we talk about fascia? Because I know on an international level, one of the big issues that's affecting a lot of research in fascia is becoming up to a unanimous agreement of what fascia is. Now, I'll look at fascia as just this spectrum of any connective tissue structure based on its density and orientation. So, for instance, whether it's tendons, ligaments, joint capsules, aponeuroses, I'll put it all into this fascial heading, but then I look at tendons as being highly dense and highly organized in the sense that the collagen fibers are arranged in one direction, which again influences its function, versus say a poneurotic fascia where it's a more flat band where you have collagen fibers arranged in different directions at different layers, again to reflect its actual function as well.
So it's sort of like, learning a sport or learning a martial art. During your years of training, you might learn specific techniques, and you're guided during that learning process. This is the technique you need to do, this is the steps you need to take, this is the outcome. And then you finish, you start practicing yourself. So as a student, same thing. You learn it, then you finish, you graduate, you start practicing as a physiotherapist, and that's when your mind actually opens, So I think and going back and using that analogy in first year and onwards, so they learn deep fascia, dense, irregular, so fibers running in different direction. And I love your example of regular, all the fibers running in the same direction because they need to withstand tension in one direction. Only.
Yes.
So if you put perpendicular to those fibers will come apart. But why do we have irregular connective tissue in deep fascia? Well, muscles expand, fascia holds it down. And then as the muscle's expanding, it's expanding in different directions. So it comes back to the structure versus function. Those fibers, let's say the crural fascia, fibers are running in many different directions because as gastrocnemius expands, the expansion is in many directions. And I really like the way you kind of grouped it, because technically, we'll go back a step and I'll say, as students learn it, they'll learn tendons to be different to ligaments, to be different to fascia. They're all different structures. And I think that helps them conceptually. So going back to, studying a sport or a martial art, here's one technique. Oh, here's one structure. This is its function. But then when you finish, you learn to put all those things together. And as Bruce Lee would say, no fixed form. It all kind of blends together, and that's what the body does. So those individual ligaments, let's look at the knee joint. So this is a brilliant example, Jack, that you've raised. The ligaments, we describe them as being capsular. So they form part of the knee joint capsule. So students will think, oh, well, these I've seen all the textbook and they just shows these kind of ligaments sitting medially and laterally.
And very separate to everything else.
Yeah, very separate. But they blend in with the capsule. And only when one prosects or dissects the specimen and scrapes the scalpel along those ligaments to see those fibers, the thickenings of the fibers of the medial collateral ligament, and then as you start to move anteriorly, see how those fibers start to blend into the capsule of the knee joint. And then trace it down inferiorly. And you think, well, this is the crural fascia now. We've entered crural fascia, but hang on, why does it have so many layers? And why are these tendons from sartorius, gracilis and semitendinosus all blending through? The pes anserinus. So I think, yes, fascia can certainly be grouped with all forms of collagenous connective tissue. And, when we study it, we need to start simply, learn individual structures, but certainly put it together and see how they function not only individually, but in a combined manner. And I think a good example is we'll talk about a prime mover muscle, and then we'll talk about an agonist, and we'll say, oh, they all work together in synergy. So I like your description because all these soft tissues, these non-contractile soft tissues, do work in synergy. And we need to do more research. in this field to see how they work in synergy.
Yeah, and look, this is something that I often question. I'd be interested to hear your thoughts when we think about how anatomy is presented, that when we start to dissect the body, we are essentially destroying that very integrated, connected system. And we know that that has an impact on not just our conceptual model of anatomy and how things are connected, but even actually from a biomechanical perspective as well. Because like, let's say for instance, if you look at, I know there's been some work by, I can't think of his first name, Wijing is his surname, from the Netherlands. I probably stuff up his surname as I do, Huijing, of looking at the force transmission capacity of a muscle in isolation versus when you remove, say, the intermuscular septum of the lower leg versus when you actually keep it in its whole form. So for instance, if you contract, for instance, tibialis anterior, you can put a force transducer in the tibialis anterior tendon. Okay, when it contracts, it produces this much force. The amount of force experienced at the tendon, though, will change based on tension of the surrounding intermuscular septum at, say, the lateral, between the anterior and lateral compartments. So if you create contraction in the perineals, you create tension within that intermuscular septum, which then creates typically a more stable platform for tibialis anterior to transmit forces potentially through the intermuscular septum. And what you see is changes in the actual force experience at the distal tendon. So all of a sudden we're starting to see changes in the force contraction and force transmission behavior of a muscle based on tension within the fascial network. And I think it's also interesting to note too, even if you look at the actual biomechanical properties of tissue, whether we isolate a particular tissue down versus in a whole form, and I know actually some of your research has looked at this too, you also see changes in the biomechanical behavior that's typically non-linear. So like for instance, if you look at like the tensile properties of an individual collagen fibre versus a bundle, you would think that surely the bundle... It's going to
be a multiplier in a linear fashion,
But you don't, you see a non-linear behavior, and that's because of the extracellular matrix will influence the behavior of the collagen tissue. And I know you've done some interesting stuff with looking at compressive forces of muscle in isolation versus a whole muscle or myofascial structure. And so I'll be interested to hear, well, one, some of your findings from that, but also two, how do we get around that? Like, how do we get around teaching, particularly people who are really going to go into healthcare and clinical work, of making sure that they have an understanding that we need to make sure we're not overly reductionistic of the behavior of tissue or the appearance of tissue when in the human form it's actually very interconnected.
Well, that's really the million-dollar question, isn't it? I'd love to be able to extend courses by another year.
Well, I guess that's a good point, isn't it?
You know, just have specific, not just one anatomy subject, have 3 anatomy subjects. Or we've already got 3, so let's say more anatomy subjects, or just extend a subject by a few more weeks. But, you know, it comes down to, for a particular allied health science, what is the governing body wanting the students to know? You know, what's the essential things? And I think this is where it relies on the graduate to, if they've been, you know, inspired to learn, and they want to continue that learning, that's where, you know, you've got a degree now, but it doesn't mean you know everything. It's just the beginning. You're only scratching the surface. So I think for education, they need to go and do some more work, do some more study. And it's really interesting when you look at medical students, the amount of anatomy that's being taught in medical programs around the world is gradually being reduced. And
seems to be a similar kind of thing, I think, happening in allied health as well. Which, as I said, we had this discussion during the week, and I think it's one of the areas that you should be expanding, not reducing.
Absolutely, and this is exactly what's happening. There's a growing body of evidence showing that you know, doctors wanting to go into surgery don't have enough anatomical knowledge, and the senior surgeons are basically saying, well, go back, study your anatomy, and then come back to sit these surgical exams. So I think, firstly, we need to do more with education. We need to inspire students. We may not be able to include all this extra work in a curriculum. You know, there's a lot of politics. money, there's time, things like that. And it's also overloading students. Anatomy is a difficult subject to learn by itself. And even though we're reducing the content, it's still difficult. And I think the way learning has evolved in the last 15 years, I think it's gone a bit downhill.
Well, I know you've gone...
I've been gentle.
I know, I see it myself working at a university myself. There are more and more restrictions being put in place in terms of what you can do based on the funding available.
Yeah.
And how actually content is taught, i.e. face-to-face versus online.
Yeah, certainly. And I think this is where we can make a difference by inspiring the students to want to learn more, go off and do their research, stay in touch with the university, stay in touch with your lecturers and colleagues. The universities are there to support not only the student but society itself. You've as a physiotherapist, you've come in to see some of my dissections. You've come into some of the classes.
Well, here's a question for you, Richard. How many others come in?
Well, I've taken some people from the St Kilda Football Club, a couple of dentists.
Okay.
So I keep.
So not many.
Not many.
Like
it takes time.
The reality is, this is quite harsh, but I know John and I went to both Melbourne University, different years, but it's quite harsh. But honestly, most of what I do clinically now is stuff I've either taught myself or done further study and research with courses or further postgraduate degrees that weren't related to my profession directly.
You're open-minded and you've obviously been inspired to learn. So let's go back, using that education and all that, and then looking at your lovely example of the leg and the perineal muscles in the lateral compartment and the intermuscular septa and the deep fascia. And I'll tie it into the biomechanics. So the crural fascia is a lot thicker than the fascia lata. And it's very interesting that the muscles in the anterior and lateral compartment, but mainly the anterior compartment, actually also originate from the crural fascia. So they have an origin from bone and the membrane? Interosseous membrane. So they have an origin from bone, interosseous membrane, but tibialis anterior, for example, its fibres originate from the crural fascia. And the only way you'll figure this out, you won't see it in a textbook, you won't notice it in the prosection unless you're paying attention, and you might notice a big chunk taken out of tibialis anterior. That's because the prosector may not have had the right technique to remove the crural fascia and keep the muscle intact. All you have to do is keep the scalpel edge, pull the fibres, look at the tension lines where it changes, colour, and then you press down on that and you can remove it. So absolutely, when the perineal muscles contract, they're pulling on the intermuscular septa. That whole lateral compartment with the fibula becomes a rigid lever, and that allows other muscles to contract. So yes, they all work together, and I think going back to the biomechanics, their properties change because they're viscoelastic. And I think we don't really teach biomechanics and anatomy a lot. So there's very little.
But they're so interconnected.
But the other issue too is we're often teaching mechanics, not biomechanics.
Yes.
And not to say that there obviously aren't physical laws that we have to adhere to in humans.
Gravity is not disappearing anytime soon.
Absolutely not. And we can think about how certain levers will alter the actual forces experienced, but at the same time too, and how forces are distributed through the body.
Do not follow those mechanical, as you said, those mechanical laws in that linear fashion.
Yes.
And I love the way you said the word linear fashion, because it's all non-linear.
Yeah.
And I think
people struggle with that non-linearity.
Yeah. And this is where John and I have talked about this a lot, and we've talked about it a lot on this podcast. And the reality is we don't fit into very simplistic principles in terms of the human body and its function. So this always comes back to me, I think, of how should we actually be conceptualizing the human body? Because these oversimplistic ways that we look at it, I think, limits our ability to understand things like interconnection, particularly interconnection between different regions of the body, and particularly for us, how that's related to injury prevalence or injury risk, and particularly high performance. And I think I see this also reflective in a lot of ways that education is taught, as it's very methodical and procedural. and that also then limits your ability as a clinician, particularly to actually think about, well, what is clinical reasoning? Because for me, it's actually, the more I learn about the basic sciences, whether it be anatomy, biomechanics, physiology, and so on, the more I can start to make a lot more sense of the presentations I see when you think about not just the presenting condition, but how other factors, whether they be physical or non-physical, influence the function of the human system, and therefore why someone actually has presented with their particular problem in the first place.
Yeah, no, absolutely. It does come down to that question, why? Why does it behave like that? What's its function? I think from an educational point of view, it takes time to get there. It takes a degree to get there. Only when students are finishing their degree are they starting to...
It's a starting point, isn't it?
Yeah,
well,
it is.
Another thing, I mentioned this before, and something I actually really appreciate about how you teach, Richard, is because I think you have a high standard and expectation, which...
And kind to say.
Yeah, which is actually a really good starting point. And a comment I made before is, you'll often set examination or assessment to make sure that these people can actually think, not just regurgitate,
absolutely.
but think.
Yeah.
And the problem is, in the short term, that creates a lot of discomfort because
course.
you go, I don't know what I need to answer here, and you get your result back and you go, I didn't do very well. And it's interesting because that can very much influence the response of the student, because they might go, oh, look, Richard really pushed me, but I tell you what, I really feel like I got much better at problem solving at the end. Like, maybe my marks weren't where I wanted to, but I feel more prepared for the next semester.
Do you think that's something that you have to explain to them, though?
Well,
absolutely.
It is, but because the issue we have, at universities, what's the biggest thing that people reflect on? It's the subject feedback.
Yeah.
And the reality is, if you're someone who teaches to the exam and they get
You
really
do
good
well,
marks,
yeah.
John was the best lecturer ever. Like, I knew exactly what I was going into when I did the exam.
It's interesting because, we've spoken about this before, Jack, but I got because of coaching, I got super interested in teaching and learning and the pedagogy stuff that was done, and even understanding a lot of the ideas that were, reading Carol Dweck's work and understanding some of that, and even these ideas of how you have to struggle with learning to actually get progression, and it's a general read book, but Joe Bowler's book I thought was brilliant on this stuff. I'm pretty sure she's at Stanford, and she just talks about a lot of the concepts of, as you said, struggling to learn is actually probably, and it's getting in that zone. People talk about Vygotsky's, zone of proximal development. It's a zone where it's difficult and that it's hard, but you kind of have enough there that you kind of are picking up, a reasonable amount of it. It can't be so far beyond your capability that you just, it's not there.
Yes.
Explaining that to people is hard because, tying that together with some of the motivational theories that I've looked at for coaching, one of them that I quite like is self-determination theory. And one of the key things that helps people stay motivated is, demonstrating to them that they're improving their competence.
Yes.
So if you give them something that's too hard and they score really poorly, say on, one of these tests or exams, they're going to think, well, I'm not very competent at this, and their motivation will go down.
Yeah.
So it's about how do you keep them...
there's a technique for that.
Yeah.
Well, it's interesting too, I know some of the... David Epstein talked about this in Range, and this is not just one article, there's actually quite a few of looking at, in terms of teaching, of that short-term lecturer who provides all these different problems to the students, which makes them really think in that short to mid-term and struggle, but actually develop more conceptual frameworks over time. They'll typically mark the lecturer lower within that subject.
But those people will do better,
as opposed to the ones who
long-term.
do better in the short term, where the lecturer teaches to the subject, does really well in the exam. If you look at their development over the following years,
those people do better.
You see the opposite. The people who actually struggled initially.
You mentioned the technique. What were you going to say, Richard?
Well, it's like taking a staircase. You've got to walk before you can run. So students need to understand, and I use the word understand rather than remember. So understand the basic anatomy so they can apply it. That's the essential basic thing. There's no point learning something if you can't apply it. How well you apply it and how well you then build upon that to add more detail and the nuances of how it works and the variations is important then. And then the problem solve, because at the end of the day, why do we learn something? So we can apply it in a real world setting, make a difference in the world, solve problems. And I think we try and train students to problem solve. A lot of the students that I teach always want to transfer into another allied health science or medicine. Physiotherapy is big. Some go on to do continue in science and so forth. But regardless of what their path is, whether it be in science or anything else, if they can learn to problem solve using one or two subjects, that's a transferable skill they can use in anything. So problem solving is the key thing, and in order to get to that, you've got to understand the structure, the topography, how it fits together, its normal function. Then look at what goes wrong.
You mentioned a number of times like structure and function and how they interrelate. And one of the things that I think has started to become a lot more popular, particularly in sports medicine, is, and I know this has gone in circles, but looking at the underlying, say, tissue architecture and how that changes based on what activities you're doing. So one that's become super popular at the moment, particularly in the hamstring research, is looking at things like fascicle length and how that changes based on the type of contraction loading that you do over a period of time or through a rehabilitation process. I just want, I guess, what your general ideas are on that, and as an anatomist who is obviously looking at something that's not changing, how do you sort of view that, and how do you sort of reconcile that with your understanding of anatomy?
I think as humans, we're very fortunate. Our mind allows us to adapt to any situation. Look at the way we've all adapted in some way to the pandemic and recovered from that. So we can adapt. Our body adapts too. So, for example, people start to hunch a bit. They keep hunching. The bones will adapt to that. Bone remodels. You go into space.
Actually, this is a good question for you, because you have some idiots who talk about this concept that posture is not important. Right, in the development of pain, right? Can you explain to these idiots on our podcast
I wouldn't use that term.
What actually happens if you sustain postures for an extended period of time to the actual connective tissue structures, to, as you said, bone remodeling? What actually happens? Because it's pretty clear if you maintain a certain posture, whether it's up to you whether you define it as good, bad, or indifferent. But what actually happens if you sustain a position?
Okay, so I'll go back to what you said earlier, because you were talking about fascicles and muscles adapting. And I think biomechanically or anatomically and functionally, everything has the ability to adapt to some extent or to modify its original structure. And that's where the pathology comes in. So we're designed to stand upright, have a fairly straight posture. The curvatures of our vertebral column are brilliantly designed to not only shunt loads through it, and if it's shunting loads in an appropriate manner, then other parts downstream shouldn't get damaged. But if we start to change the normal alignment, it's like a car. You've got a wheel alignment, tyres wear evenly. They don't really wear that badly. Yeah. You knock something, you injure it, it goes out of alignment, the tyres start wearing really badly, unevenly. Same thing with the body. So if bone can remodel itself within a few weeks, soft tissue and connective tissue can remodel itself as well. So if you keep stretching soft tissue, it will stretch. So with posture, if you're changing a curvature of the vertebral column, you start to change the intervertebral joints. You start to apply different tensile loads on the anterior and posterior longitudinal ligament, ligamentum flavum, all the ligaments around the vertebral column. And then, that changes the position of the muscle. And then the position of the muscle acting at a joint will vary. And it may not be much, but it's enough to cause pain.
Yeah. Well, we talk about this in terms of bandwidth, where initially you have enough functional capacity to deal with the bandwidth being, as you said, a little bit outside of what its maybe design function was based on the structure that it has. But if you get too far away from that, it
That-
loses that, you
Yeah.
know, resiliency to that new bandwidth.
Yeah.
And as you said, you'll start to encroach on structures that cause
Yeah.
pain perception.
That's the pathology then. Then it becomes a pathological condition.
Yeah.
Well, it starts to highlight too, like in that situation, and you would think that this maybe is obvious, but as you get those maladaptations, you're all of a sudden going to develop nociceptive signals, whether it's got to do with maladaptation of joint structures, whether it's got to do with the overcontraction of muscles because it's in a lengthened position, starts to create alterations in its local tissue environment and things like hypoxia, and develop things like trigger points, whether it has to do with actual connective tissue elongation, which is highly innervated with free nerve endings, and
Absolutely.
particularly once it starts to experience a certain amount of tension for a prolonged period of time, provides nociceptive signal. I think it's one of those things where for those people who suggest it, you almost like say, but why don't you go in this position for, say, 3 or 4 hours and see how your neck feels
Yeah.
afterwards,
Yeah.
Absolutely. We're not designed to be in certain positions, and we feel that.
And you can get into them. It's just you
Yeah.
shouldn't sustain them for any prolonged period.
And that's why the pain, our body feeds back via sensation, proprioception and pain. And paying attention to that is important. I think this is an interesting thing you raise, because there are so many pathological conditions that lead to pain. And it's a terrible thing to go through. But there are also, drug companies pushing a lot of painkillers. And I think there needs to be a fine line between...
pleasure and pain.
Yeah, I was waiting for that. Set you up well. But there needs to be a fine line where individuals can treat the pain, not just mask it. So a painkiller will just mask it, and it's coming back to the root of the problem. And sometimes it's hard, it's exceedingly difficult to treat that pain, and the only alleviation of the pain and discomfort is to mask it. But I think this is where our clinicians need to work hard to come up with ways to alleviate the problem originally. I mean, easier said than done, of course. But our body does tell us what's going on.
Well, I think also that just highlights a really simple thing that, again, I think it's just a basic first principle of looking at biomechanics and thinking about what optimal posture is. If someone is within a deviation away from that you think is contributing to their presentation, what kind of stimulus can you actually apply to reverse some of those maladaptations?
We spoke about this last week. As I mentioned to you, I went to that conference and, whether the presenter was upset or not, I don't know. But I spoke to him about not using flippant language around things like stretching.
Absolutely.
And to let you know, Richard, I went to this conference last week, and one of the presenters says, "Oh, there's no point stretching; it doesn't do anything anyway." And I kind of sat there and I thought, you shouldn't say that, because you clearly haven't read the research. 2, you're disregarding the adaptability of anatomical structures. And 3, maybe some of the people in this room are not going to go to the effort to actually dispel that information, so they'll stop giving people things like flexibility or training, and like flexibility training or stretching. And I went and spoke with him afterwards, and I said, you can't say things like that. And he said, "Oh, well, there's not a lot of evidence for it." And I said, "Have you actually read the evidence, or are you saying you've anecdotally not found it useful?" And it came to basically he was more on the anecdotal side. And I said, "Actually go and read the stuff." But I said, you actually need to go and understand what happens at physiological level when you do something like stretch. And we've spoken obviously just about postures, but I think the same thing as you said before, Jack, happens within, say, in muscle tissue. If it's in a shortened or a lengthened position, over time it starts to create pain and a level of function that is not optimal. So if that's the case, and the activity that you do promotes that sort of position being reinforced over and over, then maybe that's an appropriate stimulus that you create through stretching to actually unwind some of that, change in function or increase of nociception or whatever it is. I got quite frustrated with it, because I just thought it's a very, reduced understanding of actually what's going on at an anatomical level.
I think it's just good to have an open mind to, the research that's out there, and the way things kind of work. Would you go and play soccer without doing a few hamstrings or quadricep stretches?
Well, this is
Well-
basically the point that he was making, which I thought was interesting because he actually worked in soccer, and this is at Australian level, and I basically said to him, I said to him something that I think he didn't appreciate, but I said, do the athletes stretch even when you ask them not to? And he said yes. And I said, why do you think they do that? Oh, they've just always done it. I said, if they've always done it and they found absolutely no use in doing it, or they felt that there was no benefit, do you think that they would continue to do it and people would have continued doing it for the last 100 years of playing soccer? He said, oh, I don't really know what you're talking about. And I said to him, things that tend to be effective continue to be used. Whether we understand what they're doing or we don't understand,
Absolutely.
those behaviours will be reinforced.
Yeah.
And I was trying to get across the point that the athletes clearly feel a benefit from it. Whether they can articulate what that benefit actually is, or whether we have, say, the evidence from the research that we've done to explain what that benefit is, doesn't really mean, it doesn't take away from their experience. And they wouldn't continue to do it if they didn't actually feel the benefit of it.
And the other big thing too is context is everything, and that's the problem with, I think, a lot of research when you're getting a group of people is, are you actually subdividing them into what deficit you identify? So like again, if you see someone running and they have poor hip extension, you identify that they're quite tight through their hip flexors or have poor hip extension, and you get them to stretch and you see changes in their biomechanics. Is that not a meaningful change, particularly if it relates to
What activity they're doing.
their their biomechanical behaviour and therefore injury prevalence? But I think that's one of the big things you see in something like stretching is, there are studies where they go, oh well, flexibility was not correlated to hamstring injury or prevalence, and it's like, well, one, what was their baseline flexibility like? Because are these people that actually didn't need to really worry about stretching too much? But I think also too from the actual intervention of applying stretching is, do they actually apply enough stimulus to create a meaningful change? Because I always think of say, looking at eccentric training, particularly with something like Nordic hamstring curls. They're such a difficult exercise to do for people to do.
It's maximal and to failure, as you said.
Like when we've talked about this before, but like the idea of getting someone to do an exercise or going, all right, this is what I want you to do, you're most likely not going to be able to do it. I want you to hold on for dear life.
I'm curious if you can show me what a Nordic hamstring curl
I can
is.
show
We'll show you after this.
Okay.
A Nordic hamstring curl is when you're kneeling
You can try.
upright.
You can try it.
Sure.
Richard.
Yeah. Imagine kneeling
Try
upright.
not to tear a hamstring.
Just turn the
Yeah,
video
well.
off and
we'll put
audio
it in the show
Yeah.
notes.
Imagine kneeling upright, someone
Yeah.
holding your feet, and then
Yeah.
you leaning forward, so you're extending at the knee,
And
put your
trying
hips
to-
forward, and trying to control as you lower your body all the way down to the
Using
ground.
your
yeah,
hamstrings
that-
as the main.
So you'll be
break.
using gluteus maximus a lot as well.
Yeah, you will be.
Yeah.
Well, yeah, and the idea is because it's you're mainly moving through the knee, you're going to be loading up
Yeah,
more
if
the
you keep
distal
if you keep your
hamstrings.
hips, if you keep your hip extended.
Yeah. Well, no, yes, I know.
And gracilis
Yeah, okay, sure.
and sartorius.
Yeah, yeah.
Yes.
Yeah,
Yeah.
so...
But so,
Sorry, I just
no, but it's
I started to analyse it.
No,
it's an interesting
right.
exercise.
There's a
though, too.
biomechanist in me.
Just using that as an example.
Yeah,
of
yeah.
like very, very rarely do we give someone a particular stimulus that it's like, you're not going to be able to do this to begin with. It's
You said it last week, and I actually thought it was interesting. It's like how many times, and it's one. The reason it's probably so effective is it's one of the only tasks I think in a clinical realm where we say to someone, do something to failure.
Yeah, absolutely.
How often do you say to someone, do squats to failure, or do, if you were saying an eccentric squat, like load up as much weight that you're not even going to be able to, like lowering down is going to be difficult.
Yeah, yeah.
We wouldn't do that, right? Yet we do that with, like with a Nordic hamstring exercise.
Absolutely.
And yet we see it as being a small, like we see it as being quite an insignificant stimulus, and it's like, no, that's pretty significant for that tissue.
Yeah, and like that's I think we've talked about this before, but you look at a lot of the stretching literature, it's like, go to the first point of discomfort. And I often think like
that stimulus is not going to create a lot of change.
You've got to be careful here because it sounds like you're moving from exercise to torture.
well,
there's that too.
It's a key principle that we've talk about a lot here, and that is the principle of hormesis, and that is, are you applying an adequate enough stressor in order for adaptation to occur?
Yeah, the magnitude can't be too high though.
Oh, of course, but the reality is the magnitude can't be too low as well. That's often, I think, the big issue that we see a lot of. Are you applying enough stress for adaptation to occur? Or is it just typically more a transient neurological response that reverses rather rapidly?
Yeah, look, I think that's such a valid discussion point. For a bone point of view.
Yeah, I think that's a massive area, isn't it? Because I reckon that's one of the things with bone. People who have, say, poor bone density, or even, we have athletes who have, they develop stress fractures, and the first thing that we do is we completely immobilize them. And we had a surgeon on
2 weeks ago,
who has just finished her training, orthopaedic surgeon. And I asked her this question, but I said to her, to me, I still don't know that we're anywhere near where we need to be in terms of fracture management, because unlike most other tissues where we're finding that the tissue needs load, with bone, we're so scared we just immobilize it for as long as possible, right? And I said to her, I don't know what the balance is, but to me, it doesn't seem that it's in step with what the research suggests in other areas. Now, obviously, with bone tissue, you need a level of integrity where you're not going to, say, create disruption within the fracture, site itself. But should we be thinking about a partial weight-bearing system or a partial loading even while they're in some sort of immobilized state, because that actually is a stimulus for bone?
Well, it's going to maintain fluid dynamics within the bone, which is like the big factor.
I don't know how you do it, and obviously there's different ways of doing it. I know there's different technologies that can help support it at different amounts of weight that it'll take off and all those kind of things. But to me, that needs to start being considered more, I think, because it's the only thing that, from a musculoskeletal point of view, where we're so scared to do any loading on it when something happens to it. Even if you really tear a muscle quite significantly, straight away you're like, all right, start walking even if you can only walk and it's still painful, just walk, because we want some tension actually going through that system.
You're probably raising the concept of mechanico-transduction, which is when there's a mechanical load.
We all know about mechanotransduction.
Let Richard talk. Let Richard talk, Jack.
But that's how bone responds. It needs some sort of load to go through it. I think this is where we need to be careful and figure out, how much load.
What level is appropriate?
What level is appropriate? There are so many other factors. Age, bone strength, initial bone strength. Are there any other pathologies involved? So I think it's a bit of a can of worms when you have to try and account for all those confounding factors. And I think sometimes that's why it might be simpler to say, well, we'll just give it a bit more time. But once again, I think we need more really good, rigorous research. And I use that term a lot because there's a lot of research out there that is not rigorous. It's I don't know how sometimes it gets published.
Well, it's publishing because they need to maintain, like as I say, publish or perish. So it's people publishing garbage.
But I think, I think this is the important part, that peer review and papers that query that.
I wish peer review would say, this doesn't add anything, please don't submit this rubbish.
Well, but I think even then,
well, it probably does. You never hear about those studies, I guess.
Yeah. It's an interesting question with bone. I think a lot more work needs to be done.
I'm not suggesting I have any answers.
No, but it's a great discussion topic.
The question, it keeps coming to my mind because I just always think, well, why is this the tissue that we go, no, that's too much. Let's pull away from that.
We should be looking at it more because it becomes a big problem as we all age. And
population. There has been, there is some cool stuff that is being done where they're looking at, hypergravity sort of stuff, and or even I say hypergravity, I don't mean it in like a pseudoscience or like science fiction. No, I mean like getting people to wear things like weighted vests, like if they're older and just walking around for long periods of their day with this added weight, a 10 or 20 kilo weight vest, for instance, actually does start to increase, say, spinal loading and then create changes in vertebrae bone.
But this is a really interesting thing. So that individual has their anatomy in proportion with the biomechanical loading it's meant to be subjected to. And this is part of what my anthropometric studies on part of the muscles of the thigh and the gluteal region looked at as well. There's a proportion. There's a normal body proportion. And that proportion relates to all the muscles of the body. I just looked at a few and I noticed that proportion, but more people have looked at that. But there's a general proportion. So if our bone size is X amount, if our muscles are Y amount to support a particular load, our body mass, for example. Sorry, a particular mass. I should be careful here because mass is the amount of matter in an object, and weight or load is mass times gravity. So just being a biomechanist. So putting on, that weighted load, would that then stress out this person's vertebrae or ribs or, sacroiliac joints and then cause injury?
Well, I guess it's about, as they speak about in the hormetic process, everything's poison. You just got to work out how much to give the dose.
Exactly. So I think you were talking about, some of the findings of my research and looking at the hip. Yeah, I looked at a lot of other things, but walking, our muscles atrophy very quickly if they're immobile, as you guys know so well. But how do we kind of maintain that? And so many muscles act when we walk. So walking and thinking about it from an evolutionary point of view, we've evolved based on walking and running. So that's a great, really simple way to keep muscles active, keep the proportion. Some people go to the gym and they'll work particular muscles. And you see young guys saying, I really want, strong pecs, upper body strength. And
it's not helping their function too much.
Yeah, and they might be doing bench press a lot, so much so that they're not working their latissimus dorsi, they're not working their rhomboids, and then they tend to have a protraction, and a really interesting posture with protraction. And you think, are you coming in for a hug or something like that? But, that's changing a lot of the fascia, and this is where it comes back to your original question, Jack. If we exercise, if we prescribe exercises, if we try to increase certain aspects or certain muscles, we should be doing it so that it affects most of the body. It should be a holistic approach. Otherwise you throw things out of, and it goes back to the wheel alignment on a car, you throw things out of alignment, something's going to give, something's going to wear.
Yeah, and look, that's just reflective of a big issue we face in society, because it's only been the very recently where physical activity has become optional. It was a requirement of how we actually interacted with our environment through most of evolution and even history. But all of a sudden,
it's pretty easy to sit on the couch and drive
absolutely.
Around everywhere.
You don't need to go forage or hunt for food. You don't need to go collect wood. You don't need to climb a tree. You don't need to build. It's
Yeah, I think at least I don't order any Uber stuff. Sorry, I get a bit confused with all these things. I'm a bit of a Luddite when it comes to the technology, but if I need to order something, I'll drive out, walk to the place, pick it up, come back.
Yeah, that's fair.
So,
all right, we might wrap it up there. We've nearly hit an hour and a half, Jack.
Cool.
Great.
It's gone quickly.
Thank you very much, Richard, for your time.
My pleasure. Thank you for the invite.
This episode of Lateral Think is brought to you with the support of Strength by Numbers. Strength by Numbers have created an integrated clinical and sports performance system. The AXIT system uses force plates, dynamometry and strain gauges to objectively measure everything from isolated movements to sports performance tasks. The system has greatly enhanced our clinical practice, decision making and objectivity. We are no longer guessing. The greatest thing is its ease of use for practitioners and for our clients. There are no wires, no fixed setup. It is a fully integrated Bluetooth system. If this sounds like something that you would enhance your clinical practice or your profession, visit strengthbynumbers.com and tell them that Melbourne Athletic Development sent you.